tonight we're here to honour past, present and future researchers, and the theme for our 70th year celebrations is empowering researchers, transforming lives, and that's what that $100 million worth of research funding has done. So I just wanted to have a thank you to all those who have made it possible. To some of our donors here tonight, you have contributed so much to making researchers do what they do best, medical research. To the Goodfellow family. So for those of you who don't know, Sir William Goodfellow was very involved with the start of our organisation. Douglas Goodfellow contributed significantly through his lifetime. And then the Goodfellow family got together and made a benevolent fund. And that fund actually covers all of our administration and management costs. So my promise to you is that 100% of your donations goes directly into the cause, and that's funding medical research.
And thank you, ladies and gentlemen, for being here tonight. It is just such a pleasure as the chair of the medical committee to see you, our supporters here, the people who make all of the exciting stuff that we fund possible. I can't thank you on behalf of the research workforce of Auckland and Northland enough for what you do for us. Thank you very much. So I'd like you to give yourselves all a big hand. It is a personal pleasure for me to do this introduction tonight. So a year or two back, when I was a very junior, when I was a very junior researcher, Jane was in the Department of Neonatal Paediatrics at National Women's, and neonatal paediatrics was sort of attached to the Department of Obstetrics and Gynecology where I was based. And so Jane was one of those, even back then, and it is more than 1 or 2 years ago, isn't it, Jane? Even back then was one of those senior staff members that I looked up to and could see here was someone who you would want to emulate because they had a fantastic career discovering not just fun stuff, but actually stuff that makes a difference in the lives of people. And so distinguished Professor Dame Jane Harding is a renowned neonatologist and is currently the Professor of Neonatology at the University of Auckland's Liggins Institute. Prior to this, she was Deputy Vice-Chancellor for Research for 8 years here at the University of Auckland and has collectively more than 35 years of experience in research, teaching and clinical practice. In 2020, Jane was made a Dame Companion of the New Zealand Order of Merit for services to neonatology and perinatology. She has received the Rutherford Medal and the Prime Minister's Science Prize, along with being selected as the supreme winner at the Women of Influence Awards in 2019, and she has been the recipient of many prestigious international awards. Jane was elected as a Fellow of the Royal Society of New Zealand in 2001 and is currently the President of that society. As a recipient of AMRF funding, Jane's research discovery of a simple sugar treatment has revolutionised the global standard of care for newborn babies, helping to prevent the risk of serious brain injury in those babies. Tonight, Jane is going to tell us about this world-leading research and the latest findings on the school-age outcomes of babies that were treated for low blood sugar and how interventions during pregnancy and around the time of birth can influence a baby's growth, its metabolism, and its long-term health. Ladies and gentlemen, distinguished Professor Jane Dame Harding.
Thank you, Professor Chomley, and thank you to the AMRF for this opportunity, and congratulations to all the people involved in this amazing achievement, 70 years and so much money. I'm going to refrain from saying we're moving from the sublime to the ridiculous, merely that we're moving from the big picture to the very smallest babies. And I'm going to talk a bit about, in small picture, some of the things that Diane's been talking about in the big picture, how research makes a difference and how research here is important to make a difference here. I'm going to just talk about 3 examples, the first one in a bit more detail, low blood sugars in babies, and the other 2 just briefly to give you some ideas about how that's played out here in Auckland over the last more than a few years. So low blood glucose levels in babies, it's a common problem. Lots of babies every year. Lots of them getting admitted to intensive care. It's expensive, it's nasty. Why? Because glucose is the major fuel for the brain, and babies have big brains. So if you're short of glucose, it's the brain in a baby that's going to suffer. And it can cause brain damage. You can see the white bit in this MRI as areas of the brain that have been injured as a result of low sugars. Why? Because before babies are born, they get all their sugar across the placenta from their mum. And they don't need to worry about making sugar. And then somebody cuts the cord. And their nice constant intravenous infusion of glucose goes away, and they have to figure out how to make it themselves. And not surprisingly, that doesn't happen instantly. So you can see on the graph that the blood sugar levels fall over the first few hours after birth, and then they come back up again as the baby sorts itself out and learns how to make sugar itself. The trouble is, babies with low blood sugars don't look like they've got low blood sugar, so you have to actually test, do a blood test to find out. And the ones we know are at biggest risks are the babies whose mothers have diabetes, or who are big or small or preterm or sick. That's a lot of babies. That's something like nearly a third of all babies born. So we're doing a lot of blood tests and treating a lot of babies to try and prevent that brain damage. When I started working in this field, the first question we were thinking about is, couldn't we treat them better? Because our only options really for a baby with sugars that were low was to feed them, often with formula, which is not great for breastfeeding, and we all know that's important, or to put up a drip and give the baby intravenous sugar. That means admission to intensive care. It means separating the baby from the family. It's not good for the baby. It's horrible for the family. And it's expensive. So we started by saying, well, couldn't we do better? And the first thing we did is said, well, what are people doing now? And we asked every neonatal unit in Australia and New Zealand, what do you do about low blood sugars? And they all said, well, we treat them if they're less than 2.6. 2.6 just happens to be the magic number. We'll come back to that later. We also said, well, what would you do with these babies? One's a preterm baby, and the second one's the infant of a diabetic at term, and they both have a blood sugar of 2, so below the threshold for treatment. This is what they said. You can be sure if this many doctors are doing this many different things, nobody knows what they're doing, actually. We don't have a good answer. So we set about to doing a clinical trial. Diane talked about clinical trials. This was not a new treatment. This is a sugar gel. People had been using it on and off for a few years, but there'd never been a trial. And unless you've done a trial, you don't know for sure if it works. So we did the Sugar Baby study, or rather Deb Harris led it, and we said, does it reverse low sugar levels? You can see the gel, it's just a clear gel, and it gets rubbed inside the baby's cheek. It gets absorbed from their mouth. Well, it did worked really well. So you can see that treatment failure, that is, the sugar didn't come up, went down from 24% to 14%. The number admitted to NICU, to the neonatal intensive care unit, went down. The number who were formula feeding went down. So it improved breastfeeding. We were all really worried that it would make the baby sleepy and they wouldn't feed. But what it did was keep them with their mothers and avoid formula. So they breastfed better. And, coming back to the points just made, if you've got an effective treatment and you've done a proper trial and showed that it works, you can also show that it saves money. I think this trial cost us about perhaps $200,000, perhaps a bit less. And it's saving about $8 million a year in New Zealand now. The point that Diane made about actually it's really cost effective to do trials. And to our excitement, people caught on around the world and they started reporting, oh, we tried this And guess what? They all said admission to NICU went down, and they all said breastfeeding went up. Quite a lot. And the first publication was in 2013. Within 10 years, almost all organisations around the world are now recommending use of this stuff. Now, it usually takes at least 20 years to get something into practice. So this is, by comparison, this is miraculously fast. And it's changed lives of millions of babies and families around the world because of a little clinical trial we did here. But we're really worried about low sugar levels because we want to prevent brain injury, so we needed to know what happened to these babies in the long term. And I just mentioned that assessing long-term outcomes is not a trivial exercise. You know, these kids are all over the country. We have a great team who do the follow-up, and they go all around the country and find people and do the assessments. But it is not easy to do. It's a major undertaking. You need very generous families who are prepared to take part. You need great teams, very long time frames. You can't see what a child's doing until they've grown up. You have to wait for them to grow up. It takes a long time. And it needs lots of money because it's an expensive process. And the AMRF has supported this activity over some years. The first follow-up study we did, we called it CHILD. We wanted to know, you mentioned, I mentioned that 2.6 is the magic number that we all use. Below that's low when we try to treat. But we don't actually know if that's the right number. There's not much good research. Is it about how low it is, or is it about how long it stays down, or is it about how often it stays down? So we set out to say, what predicts outcomes in this group of 600 odd children that we knew all about their blood glucose sugars in the newborn period? And we saw them at 2 years, and there was nothing that we could measure about glucose levels that had anything to do with how they were getting on at 2. Bother. And then I thought, well, actually, maybe it's not bother. Maybe that's good because they all got treated. So maybe we're treating them at the right level and they're doing fine, and that's a really good thing to know about. So that's all right. If you think you know a good answer, don't keep looking. Because at 4, that was not true. At 4, they had worse visuomotor function and they had worse executive function. So visuomotor function is things like being able to play sport well, see hand-eye coordination, that kind of stuff. And executive function is things like being able to follow instructions and remember what you're doing and follow the rules and sit down and pay attention, and all those things are really important for going to school. So some of these children were not set up to do well at school. Again, worst thing was, even if they only had 1 low sugar, that's what we saw. Come back to that. So how did they do at school? We're now 9 years down the track. You see what I mean about long time frames? So they're 9, they're at school. They look pretty good at school. The low sugars didn't seem to be making a big effect, but they were making small differences, particular aspects of their behaviour and their ability to concentrate. But in this group, babies who are at risk of low sugars, nearly half of them had low educational achievement. So this is a high-risk group, and the low sugars might make them worse. But it's quite subtle by the time they're 9. We could still see effects on their MRIs 9 years later, even though they're treated. So if only 1 low sugar is associated with worse outcomes, all the treatment in the world is not going to solve that. We need to go to prevention. Again, something we've just been talking about. This is on the small scale. So I, of course, had this great idea and strolled into the lab one day, and everybody groans when I said I've got an idea. They go and hide. What if we could use this nice sugar gel to prevent low sugars instead of to treat them? What if we could stop them getting that low sugar, that 1 low sugar that seems to be associated with worse outcomes? And everybody said, yeah, right. And then they said, well, what dose are you going to use, Jane? I don't know. So, question one, could we find a dose that actually could prevent low sugars? That's all right, that's not too scary. 400 odd babies, a couple of years. We did that, and we designed this trial. This is Jo Hegarty, this is part of her PhD. She's now a neonatologist across the road. AMRF funded this study. And it doesn't matter about this, we just tried lots of different doses. And we did a trial, and the answer is yes, you can prevent hypoglycemia. You could find a dose, was fine. But of course, that's just treating a number. What we wanted to know is, could we keep them out of NICU? Could we actually stop them needing treatment, reduce the amount of intervention needed? That needs a much bigger study. So we're now talking about a couple of thousand babies. So we're now talking about 16 centres around Australia and New Zealand, and about 5 years to do that trial. And the answer is no, it doesn't keep them out of neonatal units. It does reduce hypoglycemia. It does increase the glucose concentrations. It is safe and effective, but this is an at-risk group. They go to NICU for other reasons. So we've prevented the hypoglycemia, but we haven't kept them out of NICU. But of course, what we really want to know is, does it improve their brains? So now you're a much bigger problem. You're looking at what happens to them when they grow up. So you're back to the follow-up. So none of these are trivial undertakings, and you can see how the long time frames become really, really important. So we had about 1,200 children to see at 2 years. That's chasing all around the country, individually assessing them all. And we're currently seeing them at 6 years. What did we find at 2 years? Well, the first study was very exciting. So this is the pre-HPOD study. This is the dosage trial, smallish trial, 400 odd children. And you can see that the higher the dose of gel they got, the better their language scores were, the better their coordination was, and the better their executive function was. Cool, we thought, this is good. It's a shame we chose the wrong dose for the next trial. But never mind, it's looking promising. Again, if you've got the answer, don't keep looking. So this is a much bigger study. This is 1,000 odd children, and they're worse at 2 years. Not much worse, just a little bit worse. What's all that about? So, again, so what are they like when they're at school? This is the first study. They were better at 2. They're better at school. Those are quite big benefits. 11% less motor impairment. That's quite a lot. So we're waiting anxiously for the big trial at 6, and we'll finish that study this year. So I'll tell you next year what the answer is. In the meantime, we're saying, no, we don't think this should be used because we don't know about the long-term outcomes. One study says benefit, one study says harm. We don't know. We need somebody else to do this study, but I don't know that anybody's going to be silly enough anytime soon. So, low sugar levels in babies. Common, can cause brain injury. We can now treat it quite effectively and cheaply, and it saves money. The gel itself only costs about $5. And prevention is possible using the gel. It does prevent the hypoglycemia, but we don't know if it helps in the longer term. So what are we doing now, apart from seeing all those children in the long term? We have just completed, and hopefully will launch in the next month, a new national guideline on managing hypoglycemia that hopefully will reduce costs nationally and will be used internationally. Coming soon. So that's the low sugar story, about 20 years' work and many thousands of people, but has made a difference here and around the world on the basis of really some very focused small studies. funded here. Antenatal corticosteroids are dear to my heart because they were first introduced by Mont Liggins, after whom the Liggins Institute was named. This is the building, this building just up there, second floor. It's the one that's got the fluorescent neon lights outside. If you go out at night, you see the coloured lights. And this is where I work. And Liggins was working when I was a student back in National Women's Hospital in the 1970s, when the survival of small babies was not good. This is a graph that Ross Howie started, and I think David Knight continued. He's in the audience. Starting in 1959, the yellow lines are the bigger babies, that is 1,000 to 1,500 grams. That's not very big, it's just the bigger of the two. And the black lines are the 500 to 1,000 gram babies. So 1 to 2 pounds of butter if you translate it into that kind of language. And you can, this is the survival, and you can see there was a huge change in the late 1970s, early 80s. There was a sudden rise in those graphs over that time. So what happened over that time? This was not social disruption. This was solving this problem. Babies, preterm babies, died of respiratory distress syndrome. And respiratory distress syndrome is really because your lungs are too stiff, because you get born early. And you can see this little baby's chest sucking into its backbone because the lungs are so stiff, can't open them very well, and babies died. Liggins and Howie were working at National Women's at the time. They did indeed work on sheep, and the sheep were indeed kept in Cornwall Park. Can't promise these were their sheep, but that is where it happened. And they were working on a completely different question of what causes preterm birth. And they managed to show very elegantly that it is the baby, not the mother, that starts labour. And the baby starts labour by increasing its level of hormones, steroid hormones. There are lots of steroid hormones, but we're talking glucocorticoids, or I'll just call them steroids to save my tongue getting tied up. And if you gave extra steroids to the mother and they crossed the placenta, you got preterm birth. And if you prevented the steroids rising in the baby, then she'd stay pregnant forever. So steroids turned out to be critical for preterm birth. And this observation that Liggins made, they made between them in fact, was that if you gave the mother steroids and therefore caused preterm birth, some of the lambs survived. Now they all died of lung disease. They should not have survived. And they correctly interpreted this as the steroids helped mature the lungs, and if it worked in lambs, shouldn't it work in people? So they went on to do the landmark trial, and this was the original trial, randomised trial again, critical thing, first part of it published in 1972. This was dramatic stuff. Mortality going from 15% to 3%. We don't have many drugs that decrease mortality like that. And this is the trial, this is the publication that David mentioned earlier that got turned down from from the Lancet as being not of general interest. But that's all right. There were lots of trials. And this is a meta-analysis. Each line is a trial. You don't need to read them. It's just each line is a trial. And the little spot right up at the top with the red box around it is the Liggins and Howie trial published in 1972. If the spot is to the left of the line, that means it's a good thing. Steroids help, in this case for lung disease, respiratory distress syndrome. If it's to the right of the line, it means they're a bad thing. You can see all the spots are to the left of the line. And the relative risk on the right-hand side is the proportionate decrease in lung disease. So 0.65, the relative risk of 0.65. If you got steroids, you had only 65% of the risk of having RDS than if you didn't. And what you can see here is there have been lots and lots of trials. They've gone through the 70s, the 80s, the 90s, 2000. We're still doing trials in 2010, and the answer is still exactly the same at the bottom. It took 20 years for the NIH finally to say, this is the American funders, to say, actually, it's quite a good idea. Decreases mortality and morbidity and saves money. Again, a trial that shows things work and save money. Actually, is cost saving. Why did it take so long? I just told you about a study that has really gone around the world in 10 years. And this is 20 years later, they're just catching on. And this is mortality. This is not just fixing the sugar levels. This is babies dying. Part of the reason, not all of it, but part of the reason had to do with this man. This is Professor David Barker with his wife Jan, who started publishing this kind of stuff where size at birth is related to outcomes many years later. Now, in this case, this is death from coronary heart disease before 65 years of age. And you can see that the small babies on the left are much more likely to do that than the bigger babies on the right. When he started publishing it, everybody said, don't be ridiculous. How can how big you are when you're born determine whether you're going to get heart disease when you're 65? And nobody believed it for a long time. But in fact, it turned out to be very strong relationship that applied to quite a lot of different diseases. And it was pretty easy to produce the same sort of thing in animal studies. And one of the early hypotheses that turned out to be easy to prove in animal studies is if you are exposed to too much steroid before you're born, then, steroids have bad press. We all know what steroids do, right? They stop you growing, they give you high blood pressure, they give you diabetes, and you can explain all of that relationship between size at birth and later heart disease, for example, by exposure to too much steroid before you're born. Ooh. So I've just been telling that steroids are wonderful things, and here comes Barker saying, actually, maybe not. And that was by no means the only reason that people were reluctant to use antenatal steroids clinically, but it didn't help for a long time. And we realised that actually we had to answer that question as to whether it actually did cause a problem in people, because when I started at National Women's, I worked with Ross Howie. He was the senior neonatologist when I was the registrar there. And when I came back from my postdoc and started on the staff, I took over the office that Ross used to have, and locked in the cupboard were the original records of the original trial. And this is me with Ross Howie and Mont Liggins and David Barker off there on the right, and Stuart Dalziel, who was the student who actually did all the work. And we took out the original records, all beautifully handwritten in Ross Howie's handwriting, and set out to find out if 30 years later, those who'd had exposed to steroids actually did have different outcomes as adults. And we said we want to know about all these things. Well, 30-year-old New Zealanders don't stay put, do they? So they were all over the place. They were all around New Zealand, they were all around the world. A remarkable number of them were kind enough to come home for the holidays and come and visit us. A remarkable number said their mothers said they had to. But there you go. And the short answer is they were fine. There was no effect of antenatal steroids on any of these things that we could find, and no effect on any of these things. So it didn't look as though the kind of doses we're using in the clinical situation, which really help babies, did not appear to have adverse effects for them as they grew up. But there was just a little difference. And this is the yellow, the orangey line is the insulin response to a glucose load. So if you and I have a big slug of glucose, big piece of chocolate cake, we secrete insulin to keep our blood sugars down. And you can see that the babies who'd been exposed, babies now age 30, who'd been exposed to the steroids before birth had to use more insulin in response to a glucose load. Had absolutely no clinical implications at all, age 30. They were just fine. But we wondered if that might mean that they were going to get their diabetes at 50 instead of 60. That's a reasonable trade-off for having less mortality as a baby, yeah? Most people would think, but nevertheless, it was important to know if it meant that we should be managing them differently. Should they have their screening tests for diabetes when they're younger? Should they be monitoring their blood pressure when they were younger? Doesn't mean that we shouldn't do it. It might mean that we have to manage things differently when they're older. So we thought it was important to find out if that indeed happened. So Anthony Walters has just recently finished that study. They are now age 50. I'm a paediatrician. I don't know anything about 50-year-olds. Fortunately, other people do, and 50-year-olds who were in this trial, 2/3 of them by the time they were 50 had some kind of cardiovascular risk. A lot of them born preterm, and preterm is a cardiovascular risk. But it didn't look like steroids have any bad effects. So that's really important for the world who have been reluctant to use steroids. And we have pretty conclusive evidence now, I think, that they're fine at least up to age 50. How much longer do you want to wait? Moving on to neonatal nutrition, very briefly. This is a problem for preterm babies. And very preterm babies are rapidly growing their brains. They should be in utero, so in this case they're doing it while they're in the nursery. And over the last few weeks of gestation, the brain volume increases by 22 mils a week. Think about 22 mils of anything. That's a lot of brain to grow every week. Yeah? 34 weeks, only 6 weeks early. Not something we worry too much about these days. They're fine in the nursery, but they've got only 2/3 of the brain size they should have when they're born. So nutrition over that period is really, really important to grow your brain. And there's been data for a long time, this kind of stuff, that says if you don't grow well, you don't grow your brain well. The white bars are the rate of impairment. The blue bars are the rates of cerebral palsy. And across the bottom is the rate of growth, weight gain in grams per kilo per day. So if you don't grow very well, if you're on the left side of that weight gain, you've got a much higher risk of having poor outcomes than if you're growing well. So we think nutrition is something that we must do as well as we can in the neonatal unit. And the problem, one of the problems with very preterm babies is it's really hard to get good nutrition into them, particularly over the first week or two. What you see here is protein intake before birth. It's nearly 5 grams per kilo per day. It's a lot. And then they get born. And we really struggle to get enough protein into them in that first week or two, for all sorts of reasons that we don't need to go into, but it's a challenging time. So we wondered if that period was a really critical period for brain growth. And if we could do something about that, could we improve outcomes? So we're back to a trial, a randomized trial. Could 1 extra gram of protein a day given to these babies over the first week make a difference? This is Barbara Cormack and Frank Bloomfield who ran this study. 400 odd babies in 8 centres. You can see on the right that indeed the ones who got the intervention did get more protein. That was what we tried to do, and it did work. They did get more protein. Worked very well, but it didn't make them grow. Bother. So you can see that this is weight change right up to 2 years of age. The outcome of the study was 2 years of age, and it made pretty much no difference to their weight gain at any time. Of course, the main outcome here was, how are they doing? We're worried about brain growth, so we said the outcome was a 2-year developmental outcome. And what were they like at 2 years? Well, on the left, you can see that it made absolutely no difference to their survival without disability, but they were more likely to have severe disability. So that extra protein looked like it was not a good thing. That's disappointing, but it's really important because in the last 15 years, the international recommendations for how much protein these babies should get has been going up and up and up and up and up. And we've now said, no, we're overdoing this. There's all sorts of reasons why that might be, but the point is, unless you've done the trial, you don't know that. And now that we do know that, the international recommendations have come down, and we're probably getting better outcomes. So, in these tiny babies, the extra protein doesn't improve outcomes, it doesn't improve growth, and it may be damaging. And we have changed practice around the world on that basis. So New Zealand research is making a difference to babies here, it's making a difference to families around the world, and the AMRF has helped make it happen. Thank you, all of you. And thank you to all of the team who really do all the work.
That was absolutely fantastic. Thank you, Jane. And when I know, because we funded Dr. Anthony Walters, who was doing the 50-year study, and it was pretty incredible to know that 50 years prior there'd been this study done that had made these revelations, and then to actually be able to fund something else that actually proved that the outcomes, that there was no adverse outcomes, was amazing too. So yeah, stunning work. Thank you very much, Jane. So now is time for our question and answers.
You were talking about hypoglycemic babies. Is there a danger of making them hyperglycemic?
There is indeed. We've done quite a lot of work on that as well. The sugar gel doesn't make them hyperglycemia. We've looked at that very carefully. It's really a very small dose, and they never go high on it, as opposed to if they've got intravenous glucose, when they can easily go high. We know that high sugars are associated with bad things, but we're not quite sure how best to treat that. But I think we've shown conclusively that the bad things do happen as a result of high sugars, just like they do when you're adults, right? High sugars, if you've got diabetes, are not good for you. Same is probably true in babies. Treating them is another matter, and we have done some trials on that, but don't have time to talk about that tonight.
Just another little anecdote from Liggins. It took the Royal College of Obstetricians and Gynecologists in England, or UK, slightly less time to recommend steroids than the Americans, but it still took decades. And Liggins said that he thought the reason for this was that the Royal College of O&G didn't believe that anything good could come out of the colonies.
Pretty much the same phenomenon as we heard earlier regarding the American view. Anything happening in New Zealand was not valuable, but that was certainly a thinking. That was what Liggins and Howie told us at the time. They thought that's why, one of the reasons.
It's a big ask, Jane, but have you been able to make any kind of estimate of the cost savings to the community? And I mean not only health, education and other things related to children as a consequence of the brain damage avoided.
We have done some estimates. They're not very robust, and we're going to do them again when we've finished our current study, because then we'll know what they're like at school, and that'll give us a much better idea of what the actual benefits to the community are. Our early estimates were there was definitely a cost saving, but that was when they were younger, and we need to know really at school age to do a more accurate estimate. But I showed you the healthcare savings of 8 million, and there is a lifelong saving probably.
Oh, hi Jane. Is the dextrose gel just to clarify, active best practice currently?
Yes,
Yeah.
it is. And the nice thing about it, apart from the fact that it's very cheap, is that it needs very little special handling. It doesn't need to be kept in the fridge. It doesn't need, it's pretty robust, so you can use it anywhere. So it's being introduced into many low-income countries because it's, it's cheap and it's easy to manage.
Thank you.
You can buy it commercially now, but it's not technically a drug. So there's not the problem of the drug companies making lots of money on it. And in fact, for the first study, we made it ourselves in the hospital lab.
Oh, one question. Oh, no.
So you're still waiting for results on the 6-year follow-up for HPOD, and you mentioned that there are studies that show it's beneficial but also harmful, so it's not recommended just yet. I was wondering, is there any theories as to why it seems harmful for development?
We have no idea. It may just be a chance thing. I'm guessing it's going to be the same at 6, but I don't know. You'll be around when we find out. I don't know. Where we're at the moment is, although we're not recommending it routinely, it is being used in some parts of the world because it helps reduce hypoglycemia and then reduces interventions. And there's in the new guidelines that are about to release, the panel who put together the guidelines were strongly of the view that we should not ban it. We should say, can be used if everybody's well informed, but the long-term outcomes are uncertain. The fact is that if families, for example, if mother's had diabetes and and her baby had a terrible time with low sugars in the previous pregnancy, and she's in another pregnancy, she's going to ask for it.
So I know we all appreciate Jane's presentation tonight, and I think similarly, Jane, you have made an incredibly complicated research area sound easy and put it into terms that we could all easily understand. And I think everyone sitting in the audience tonight will know why Jane has the title of Distinguished Professor Dame in front of her name. So we really can't thank you enough, not only for sharing with us tonight, but everything you've done for the research community and for all those mothers, babies, families that now have survived and are living a much better life. So on behalf of us all, thank you very much. So that tonight is the wrap-up for this evening's presentations. I wanted to thank you all. 3 hours is quite a long time to be sitting here with us, but I hope you'll all agree that the calibre of presentations. So, thank you very much. Thank you to our wonderful 3 presenters, and thank you everybody for coming, and we hope we will see you at the next event on May 22nd. So, yeah, there's information available on that. Another exciting speaker series too. Thank you so much.